We're going to focus in on a very important topic called pharmacogenetic testing. This is a new frontier in personalized medicine, and it is so significantly important for your practice. My name is Sunil Wadhwa. I am the founder, CEO, and president for MyMedX Halo. You'll be joined on this call by Dr. Peter Dimitri as well as Dr. Louis Melz. I also want to extend just a great thank you and a warm appreciation for our scientific advisory board members. These doctors have been very instrumental in helping us get the word out to the clinics in the U.S. Now it's my pleasure and honor to present to you our Chief Medical Officer, Dr. Peter Dimitri. He's a former United States Air Force Assistant Surgeon General and a fighter pilot. He has a very impressive background. I want to just point out a couple most impressive things that he's accomplished. He's a colonel, retired from the U.S. Air Force after 28 years of active duty. Incidentally, the Air Force implements a $6 billion global healthcare system. He got his BS degree with honors from the U.S. Air Force Academy in 1978 and his medical degree in 1986. He graduated from the Air Force prestigious test pilot school in 1991 and holds the distinction as the only test pilot physician in the Air Force history. He received his medical residency at Harvard in 1998 and was selected as the chief resident in his class, lifetime member of the Society of Experimental Test Pilots with operational test experience in the A-10, the F-4, the F-15, and the F-16 jet aircraft. He's flown over 37 different types of aircrafts, logging about 2,300 fighter and test flight hours. It is my pleasure again to introduce Dr. Peter Dimitri.
Thanks, Anil. I'm so delighted to be here with all of you today. This is such an exciting time in medicine, and by excitement, sometimes it's good excitement and sometimes not so good excitement, as I know all colleagues know. I don't remember another time when so much was changing. In many ways, things are so much better than they were 100 years ago, but in other ways, some things are worse. Medicine, I think, is at a crossroads like it's never been before. I believe that we're about to leave an era of epidemiological or statistics medicine to enter the much preferable era of personalized medicine. After all, medicine is locally delivered, kind of like politics, and it's a very personal matter to be on the receiving end of a doctor's script or examining table. And what I mean by that, of course, is that the patient seeking medical care, whether it's a patient or whether it's us seeking care from colleagues, is really focused on their outcome, not the other 99 out of 100 folks, but their outcome. It's a 0 or a 1. It's a success or failure or a complication, and it's my outcome that I really care about. So for the first time, personalized medicine, this new era, can start handling this new paradigm, and it really is an exciting era and a new frontier, as Sunil was mentioned. We talk about integrative medicine, we talk about personalized medicine, and I have to wonder sometimes as I hear colleagues talking about it, is it lip service, or how are we really going to start down that path and really personalize care? I'm especially thrilled to be part of the HALO family, and it is a family. Our mission is to save lives and improve patient safety, and we're out to do it clinic by clinic until every clinic around the country has been reached. It's time to get the technology out of academia, in my opinion, out of the laboratories and into the clinics, because it's truly ready for everyday usage. We need to get it deployed into every doctor's office in the country, and we're driven. And our motto is every clinic and every patient. Up until now, in the past, patients were given medication based on large, multi-centered, double-blind, randomized clinical trials, and from there the profession created the empirical basis or a statistical model on how to treat patients. And of course, we know the assumption was that in a sufficiently large sample, that the statistics, or what I like to call the sadistics, would allow all to balance out to make the answers apply to the rest of us at the individual level. We just hope that the patient that we were seeing fit under the bell shape of the curve. And I have to tell you, most physicians I speak to really think that the serious adverse reactions, if it's going to happen, it's likely to happen to somebody else. And they hope and maybe they plan for it to happen to some other lesser clinician down the road from where they practice. Well, I have to tell you, the numbers say differently. The mortality and morbidity statistics that I'm about to share with you prove that this approach of statistical risk mitigation may not work so well in human biology, where the genetic makeup is different among each of us. Here are some statistics, and they're pretty sobering to me. And I have to tell you, when I talk to most of you, most of the colleagues that I go when I travel from city to city, they kind of say, yeah, they kind of knew about it, but I think most of us find it sobering when we really study them. Imagine 2 million hospitalizations from adverse drug reactions. That's 2 million hospitalizations at a cost of over $136 billion in additional annual costs. Another 200,000 trips to emergency room. But here's the real clincher. The real clincher to me is that adverse drug reactions are now the fourth largest cause of death in the United States. And that means 106,000 people died from them annually. Now, that 106,000, that's not our number. That's the number provided from the government. And in my preventive medicine background, I'm here to tell you that when someone gives me a number like that in preventive medicine, it's normally underreported. So when I'm in medicine, when I think about these kind of problems, I like to think of them back into aviation. And when I have an aviation problem, I come back to my medical background. So that 106,000 people killed from adverse drug reactions, that's the equivalent of a jumbo jet, a Boeing 747 with 300 passengers aboard, crashing every day of the year. Now, ladies and gentlemen, that's carnage in any industry. And that sounds like a war zone in my military background. And for any other situation, there would be congressional hearings and the industry would be shut down. And this from our profession. We providers who took an oath, to do no harm. Now, I'm not throwing pejorative arrows our way. And I know that back in the time, and I've been practicing for 30 years, if we didn't know any better, if we didn't have other tools, then we could in good conscience say, we're doing the best we can. But that rationalization doesn't work much anymore. It's not in my opinion anyway. We know better. And if we don't change the practice by using pharmacogenetics, then it's closer to we either don't care or we choose to be negligent, neither of which of those are acceptable. This pharmacogenetics technology is FDA-approved technology. It's already been around for many years. It's used by many large academic centers like the Mayo, the Clinic, Stanford. Insurance plans frequently cover it. And our mission should be to rapidly transition this technology into every doctor's office. And I think personally, and I'm talking to doctors who are actually embracing it, I think as doctors embrace this additional layer of safety for their patients, those who do it will be rewarded well. And those who want to wait another 10 years will see their patients vote with their feet and seek out and find other physicians who will actually provide an extra layer of protection to stop this carnage from going on. The one last point that I really want to leave you with is that the timeline historically in medicine to adopt new clinical technology is close to obscene. You know many examples like I do, starting with Semmelweis back in the 1800s, where he pointed out that, hey guys, washing hands is a good idea. It took, nearly 100 years before we all said, well, maybe that guy had an idea that, his time has come. Peptic ulcer disease for another half a century, traumatic brain injury for 25 years, and we're still kind of just starting to bend that curve back. And there are other instances where the answers were clear, but the profession had to be forced to do the right thing. This transition, though, however, is going to be much faster for two reasons. First, I think patients are getting the word, and they're starting to ask their doctors for the tests. And they'll vote with their feet because there's a consumerism out there now that is much smarter than we've ever seen in the past. And second, and this one's a little untoward, is that the lawyers are becoming knowledgeable as well. In fact, I was talking to a colleague of mine that I served 20 years with in the Air Force who's out in civilian practice in the Midwest. And he pointed out about something that I hadn't ever known about, but it was headline news out there. And some of you who know the story will immediately know exactly what I'm talking about, but there are now doctors being prosecuted for adverse drug reaction under manslaughter. Now, the manslaughter charges were in fact dropped. They weren't dropped. He was acquitted, but he certainly found himself bankrupt. He found himself unemployed. He found himself unemployable, and he's still essentially a ruined man. Now, that would really was secondary to adverse drug reactions. The other interesting thing that's happening is in the legal profession is I saw another two notes that came across in the last week, and one was upstate New York, and it was a group of lawyers saying to all the parents, hey, if your child has had an adverse drug reaction, then come talk to us. And again, the whole concept of adverse drug reactions do no harm. There are tests out there that can preclude and prevent many of the adverse drug reactions. I think that the legal profession is going to drive us to do the right thing, and I hate to say that the lawyers are going to make us do the right thing, but I think that's what's going to happen. Folks, my position is that it's time to leave the era of epidemiological or statistics medicine and really, with both feet, come into the personalized medical care, one where using pharmacogenetics helps the doctors and the patients get to the right information for the right drug at the right dose and getting from the beginning. After speaking with many of my colleagues to date, none of them, after speaking with me, could defend or make an argument that there was any justifiable reason not to do this. I look forward to meeting each of you as I travel all around the country all the time, and it's likely that I'll be in your cities to meet with you, and together I'd like nothing more than our profession to turn these statistics around. Sunil, I'd like to turn it back over to you.
Dr. Dimitri, thank you so much, and now it's my pleasure to turn over the presentation to Dr. Louis Meltz, an amazing doctor here in California. He is part of our scientific advisory board. Dr. Meltz, please share with all the healthcare professionals on the line some details about this testing process.
Thank you, Sunil, and thank you, Dr. Dimitri. One of the things that is so impressive and so compelling from this test is that it is indeed a life-saving test. And this test is not only, as Dr. Dimitri noted, endorsed by Mayo, Stanford, Vanderbilt, Duke, Johns Hopkins. They are using this test because they realize the importance of testing their patients beforehand. You know, even the Associate Director of the FDA recognizes how there are so many genetic variations from individual to individual that now allows how to predict the response. This truly helps a person do precision prescription writing to decrease that chance of that adverse event and increases the effectiveness of drugs. You know, even the new drugs coming out are even more and more effective, but they can be more toxic. And this is why it's more important to know who is being prescribed from the very beginning. That's right. Dr. Dimitri said it was the right information, using the right drug in the right dosage for the right patient right from the very beginning, because no longer has our medication history been the one-size-fits-all. It's no longer shooting from the hip. It's no longer looking at Hippocrates, knowing what it's going to do. Now you know exactly what it will do in your patient. This is the five-legged chair approach to your practice. It improves patient care, patient satisfaction, compliance. It reduces your liability as a physician, and it improves your risk management. This truly is personalized medicine. Even the FDA has 130 black box warnings on drugs recommending this sort of pharmacogenetic testing. And of those 130, there are 16 with a frank black box warning that compels and requires this testing before a catastrophic episode can occur. This is the reason why we are forging forward in this area. Again, these are statistics. I want to emphasize and drive these home. 2 million ADR hospitalizations. These aren't just the ones that suffer silently at home. These are the people that get admitted because of a potential life-threatening situation. And you can see the numbers. It's just unbelievable, the fourth leading cause of death that we have led and turned a blind eye to, and the astronomical cost and heartache this causes, not only for our economy, but families at large. When we start looking at people in polypharmacy, 4, 5, 6, 8 drugs, some elderly on as many as 20 drugs a day, we know that anyone on 11 plus drugs per day has a 96% chance of sustaining an ADR. And with this sort of testing, we can reduce the statistic very, very significantly and have better prescription practices in our offices. And this is what we're presenting now. We know that from this pharmacogenetic testing, we can identify ultra-rapid metabolizers, extensive metabolizers, intermediate and poor metabolizers. Those that take medication and they quickly approach a toxic range, and those that don't even come close to a subtherapeutic dose range. But now we know this is possible beforehand, before ever prescribing, by taking just a simple test. You can see here that even on, say, Elavil, Someone who is a poor metabolizer would have half the dosage to be equally as effective as more than twice for an ultra-rapid metabolizer. This is the way we can dial in and drill down and know exactly, rather than that experimenting of titrating up and then finding out the medication doesn't work and titrating down and another one and a third one. Now you're 3-4 months out of someone just suffering along with their hot flashes, their weight gain, maybe there are other psychological problems, when it can be ameliorated easily, quickly from the beginning with a simple pharmacogenetic test. And these are the sort of things we understand. It's so sad. We have many case studies. Here's an example of a 30-year-old woman. She gives birth, and for the episiotomy, her physician prescribes her codeine for the pain. She begins breastfeeding, and within 2 weeks, her infant dies of a morphine overdose. Had her physician tested her pharmacogenetically to identify the 2D6 pathway, they would have understood that she was an ultra-rapid metabolizer and an unlikely candidate for using a prodrug, and an alternative and a change could have occurred. I would hope to think that this infant would still be alive had this pharmacogenetic test been performed. And there's many cases between warfarin and blood thinners and other antiplatelet therapies. And we've got a 9-year-old boy, ADHD diagnosed, placed on clinidine and Prozac, develops symptoms of low-grade fever, incoordination seizures, he dies. Now, had the physician tested this young man, determined through the 2C19 pathway he was a poor metabolizer, an alternative could have been used. In the same example, I would hope that this young man would have been still with us had this test been performed. These are the type of cases that attorneys are actively trolling for litigants. And this is, again, why we need to be so defensively minded in our practice. Very simple. This test is a simple buccal swab to obtain the DNA specimen, put in a prepaid Federal Express envelope, shipped to the lab. The lab receives it, does the test, and returns the results either by a secure web portal, secure email, or fax. The laboratory isn't just a DNA testing laboratory. They do pain management, drug testing, forensic toxicology, biologic monitoring, and their laboratory scientists, their pharmacist, and their medical director are available for consult for recommendations and alternatives should you have a positive test that comes up. What makes our opportunity so unique and unlike any other testing that you've done? You've probably done DNA testing and urine toxicology in your practice, but you have never ever been paid for obtaining the specimen. You know, maybe you've gotten a little bit for conveyance of the specimen, maybe the use of a cup, a Noble or a Discovery cup, but not what we have in store for you, because we have a NDC-coded DNA testing cup that allows a doctor to bill through a private pharmacy benefit manager and bill through a patient's pharmacy benefit and receive between $400 and $700 for obtaining the specimen in this manner. Physician purchases the cup for $100. Doctor uses 10 test kits a day. Say 3 are paid for and adjudicated. Of those 3 kits that are adjudicated, and the average reimbursement is $500, if you're still working 20 days a month, 3 adjudicated tests at $500 each times 20 days a month, that gives you an additional revenue stream of $30,000 of something you're already doing but you've never been paid to do. That's $360,000 of an additional revenue stream that's just being missed only because you didn't know it was available until now. In addition, an active medicated specimen collection kit for urine drug toxicology. We have a unique specialized NDC-coded kit. It's $85 for your dispensary. The profit is about $200 per test. Doctor does 10 tox tests a day. 10 are adjudicated. You do 20 a month at $200 each. That's another $40,000 per month in an added revenue stream, about $480,000 a year. When we look back at the example before, between the DNA collection and now the urine drug toxicology, we're looking at almost $850,000 of potential added income for something that you are already doing but not getting paid for. That's obtaining a DNA specimen and obtaining a urine drug toxicology specimen, but now you're getting paid for obtaining it and the work that you're doing using these specialized NDC-coded, FDA-approved kits. Unbelievable opportunity for those that see the vision, for those that are entrepreneurial-minded, opportunity. So what you need to do right now, what you want to do, is to get back with the representative who invited you to this webinar. Simple as that. The person who approached you, that told you of this opportunity, get back with them. We'd be happy, Dr. Dimitri, Sunil Wadhwa, myself, or any other person on the Scientific Advisory Board, our management team, our executive team, more than happy to set up a conference call with you, answer any of the questions you have. And it's an extremely simple process to set up your practice. A couple sets of forms, and you're ready to go.